I'm doing this to revise for my abnormal psychology / psychopathology exam. I have like 20 questions, and since I'm good in class presentations, I'm going to read these notes, questions and answers, really, like as if I'm doing a class presentation so that they can stick. I don't want to fail. So there are about 20 questions. Define psychopathology. Psychopathology is a scientific study of mental disorders, including their causes, etiology, symptoms, development, diagnosis, treatment, and prevention. It examines abnormal thoughts, emotions, and behaviors to understand and manage psychological disorders. Distinguish between normal and abnormal behavior. So normal behavior is consistent within cultural and societal norms. Would that be within? Yes, within the cultural setting and the societal setting, but I still think even outside that cultural societal setting, if someone is aware, then that would be normal behavior. I'm not sure I would write that in an exam. Maybe further clarification. Abnormal behavior is behavior that significantly deviates from cultural expectations. Normal behavior does not interfere with daily functioning. Abnormal behavior causes impairment in social, occupational, or personal functioning. Normal behavior produces little to or no distress. Abnormal causes significant distress or suffering. Normal behavior does not pose danger to self or others, and abnormal behavior may pose danger to self or others. For instance, in a community where girls get married once they're 18, 19, 21, they're already married, and if you're 24, 25 or older and not married, that would be seen as there is a problem. So if a girl decides she's going to pursue my storage journal, I don't know why, and not get married, she would be under a lot of distress because there'd be so much pressure to get married. She'd be called names. For instance, in China, you'd be called a leftover woman. In the Luo community, you'd be called what is this thing called? I've forgotten. Yeah, that's what it would be called. Then explain the 4 Ds of abnormal behavior. The 4 Ds are distress, dysfunction, danger, and deviance. Those ones, at least I know them in my head. Deviance is behavior. Behavior differs markedly from societal or cultural names, and they are actually, let's start from the top. The 4 Ds are criteria commonly used to identify abnormal behavior. We have deviance, which is behavior differs markedly from societal or cultural norms. The girl deciding she's not going to get married at 18, 20, 21. She wants to get married like when she's way older, when she's achieved all her dreams and educational pursuits. Distress, the individual experiences significant emotional or psychological suffering. Dysfunction, behavior interferes with daily functioning, including work, relationships, or self-care. Danger, behavior poses a risk of harm to oneself or others. Distress can be experienced by someone who doesn't have any abnormal behavioral psychopathology, but as a result of being around someone with abnormal behavior or psychopathology. A diagnosis is based on a comprehensive assessment, not on the presence of one criterion. Describe the biopsychosocial model. The biopsychosocial model explains mental disorders as the results of interactions between biological factors, psychological factors, and social factors. Biological factors would be genetics, brain structure, neurotransmitters, hormones, and medical conditions. Maybe you have chronic illness, or you are born with an extra chromosome or something. Psychological factors: personality, cognition, emotions, coping skills, trauma, and learning experiences. For biological factors, if we're looking at nature versus nurture, biological factors would be nature, and then psychological factors could be both nature and nurture, but I would put this for nurture, even the environment. Social factors: family relationships, culture, socioeconomic status, life stressors, and social support. If 2 children say they are twins, they are adopted separately, one in a very, very high socioeconomic status and one below the poverty line, then the 2 of them, their behaviors will not be the same. If the one who is taken from below the poverty line and brought into the life of someone who is living very well, for instance, now something happens and they're removed out of poverty, probably because they perform exceptionally well in school, and they are put in a very private, high-class institution, it would be very, very difficult for them to adapt, and it would cause them significant stress. The holistic model guides assessment and treatment by considering multiple contributing factors, and the holistic model is the biopsychosocial model. Differentiate between DSM-5 and ICD-11. I don't think this would come because I know DSM-5 is what's used by psychologists worldwide, and ICD-11 really stays with the World Health Organization. But anyway, the DSM-5 TR, text revision, that's what TR stands for, is published by the American Psychiatric Association. ICD-11 is published by the World Health Organization. DSM-5 focuses mainly on mental disorders. ICD-11 covers all diseases and health conditions, including mental disorders. You'll find that they're talking about tuberculosis in the ICD-11. DSM-5 TR is widely used in psychiatric diagnosis, education, and research, especially in North America, while the ICD-11 used internationally for diagnosis, epidemiology, health statistics, and insurance coding. The DSM-5 TR is still used worldwide. DSM-5 TR provides detailed diagnostic criteria. ICD-11 provides diagnostic guidelines and standardized disease codes. So now, what is the ICD international criteria for diseases version 11? I think that's what the ICD-11 stands for. The 11 I know is the version. And then DSM-5 is the Diagnostic Statistical Manual for Mental Disorders. Diagnostic and Statistical Manual for Mental Disorders, version 5, text revision. Explain the importance of differential diagnosis. Differential diagnosis is the process of distinguishing one disorder from other disorders with similar symptoms. It is important because it ensures an accurate diagnosis, guides appropriate treatment, prevents misdiagnosis, reduces unnecessary medication or interventions, improves patient outcomes. State 5 symptoms of major depressive disorder. According to the DSM-5 TR, 5 or more symptoms must be present for at least 2 weeks, with at least one being depressed mood or loss of interest. Examples include depressed mood most of the day, markedly diminished interest or pleasure, that's anhedonia, significant weight loss or gain or appetite changes, insomnia or hypersomnia, fatigue or loss of energy, feelings of worthlessness or excessive guilt, poor concentration or indecisiveness, recurrent thoughts of death or suicidal ideation, psychomotor agitation or retardation. Question 8. Differentiate delusions from hallucinations. Delusions are false, fixed beliefs that persist despite evidence of the contrary. Hallucinations are sensory perceptions that occur without an external stimulus. Delusions affect thinking and beliefs. Hallucinations affect the senses, hearing, seeing, smelling, tasting, or feeling. For example, an example of a delusion is believing the government is monitoring one's thoughts, believing the crows are spying on you. An example of hallucinations is hearing voices when no one is present, even seeing people when there's nobody there. In certain countries, there are dogs that are trained to help people with, say, hallucinations, or let's just give it the main thing, schizophrenia. These dogs are trained that when this person says, say hello to so and so, the dog only says hello to who they can see. If they can't see anyone, then the person who has this emotional support, mental support dog is able to know, oh, so that is a hallucination, and it really, really helps them. At least they are not able to sit there and feel like I'm crazy because nobody can see who I'm seeing, nobody can hear what I'm hearing. Describe positive and negative symptoms of schizophrenia. The positive symptoms are added experiences or behaviors. Delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior. Positive symptoms do not mean that this is a good thing, Negative symptoms involve a reduction or loss of normal functioning. So we've seen positive symptoms are added experience or behaviors. Negative symptoms involve a reduction or loss of normal functioning. Positive, to add. Negative, to remove. Flat or diminished emotional expression, flat affect. Reduced speech, alogia. Lack of motivation, avolition. Reduced ability to experience pleasure, anhedonia. Socially withdrawn, asociality. I feel like whatever I've put in brackets and I've added at the end of each sentence, if someone was doing clinical psychology, that would be very, very important, but I like going the extra mile. Explain the role of neurotransmitters in mental disorders. Neurotransmitters are chemical messengers that transmit signals between neurons. For instance, serotonin is associated with depression and anxiety. Dopamine. Excess dopamine is linked to schizophrenia. Reduced dopamine is associated with Parkinson's disease. Norepinephrine. Is it norepinephrine? Norepinephrine. Yeah, that one. It influences mood, attention, and stress responses. GABA. Reduced GABA activity is linked to anxiety. So what was GABA in full? Glutamate. Abnormal glutamate functioning has been implicated in schizophrenia. Imbalancement in neurotransmitter systems can contribute to the development and maintenance of mental disorders. And you remember the biopsychosocial model, where biological factors can contribute to abnormal behavior, and the neurotransmitters are here, biological factors. Differentiate generalized anxiety disorder from panic disorder. This is like differential diagnosis of generalized anxiety disorder and panic disorder. Generalized anxiety disorder, GAD, there is persistent excessive anxiety about multiple areas of life. Panic disorder, recurrent unexpected panic attacks. Generalized anxiety disorder, symptoms last at least 6 months. Panic disorder, panic attacks are sudden and reach peak intensity within minutes. So you can see generalized anxiety disorder at least 6 months, and then with panic disorder, sudden and reach peak in intensity within minutes. Someone can have generalized anxiety disorder and also have panic disorder, by the way. Worry is continuous and difficult to control in generalized anxiety disorder. With panic disorder characterized by intense fear and concern about future attacks. So that's called comorbidity, the presence of more than one condition. Explain obsessive thoughts versus compulsive behaviors. Obsessions are recurrent, intrusive, unwanted thoughts, urges, or images. Cause anxiety or distress, for example, persistent fear of contamination. Compulsions are repetitive behaviors or mental acts performed to reduce anxiety caused by obsessions. For example, repeated hand washing or checking locks. Individuals with obsessive compulsive disorder may experience obsessions, compulsions, or both. Set the diagnostic criteria for post-traumatic stress disorder. According to the DSM-5 PTSD requires exposure to actual or threatened death, serious injury, or sexual violence, kind of like existentialism. Intrusion symptoms, e.g. distressing memories, nightmares, flashbacks. Persistent avoidance of trauma-related stimuli. If you're brought up in an environment where there's a lot of war, or it could have even been your father was always beating your mother, like you are brought up in a family setup where domestic violence was rampant. Even if a glass falls, even if a door bangs, even if you hear footsteps that sound like the footsteps you had before your mother was beaten, then that's going to be persistent avoidance of trauma-related stimuli. Negative changes in thoughts and moods, marked alterations in arousal and reactivity, e.g. hypervigilance, startle response. And that, to me, is similar to persistent avoidance of trauma-related stimuli. So for the avoidance, it's like you'd want to live in a very quiet place. You would not, even when you're placing your glass somewhere, you want to make sure, it's like you have an obsession in how you place your glass down so that nothing can touch it and drop it, nothing. Even the door, there's a way you always shut the door or leave the door open so that nothing can bang that door. Symptoms lasting more than 1 month. Clinically significant distress or impairment. Symptoms not attributable to substance use or another medical condition. All the symptoms mentioned above should not be attributed to a medical condition or substance abuse. Differentiate bipolar 1 and bipolar 2 disorders. Bipolar 1 requires at least 1 manic episode. Bipolar 2 requires at least 1 hypomanic episode and 1 major depressive episode. So you see, bipolar 2 requires at least 1 hypomanic episode and 1 major depressive episode. Bipolar 1, the mania causes marked impairment or may require hospitalization. Bipolar 2, hypomania is less severe and does not cause marked impairment. Bipolar 1, major depressive episodes may occur but are not required for diagnosis. Bipolar 2, storage ran out, now we are back. So we're talking about bipolar 1, major depressive episodes may occur but are not required for diagnosis, and bipolar 2, major depressive episodes are required. Now we describe the cluster classification of personality disorders. Personality disorders are grouped into 3 clusters. Cluster A, which is odd or eccentric, there is paranoid, schizoid, and schizotypal. Cluster B, we have dramatic, emotional, or erratic, which is antisocial, borderline, histrionic, narcissistic. Cluster C are anxious or fearful, which is avoidant, dependent, obsessive compulsive personality disorder. In class, the lecturer asked us, who do you think is bound to marry the other amongst these class personality disorders, or who are bound to date each other? I personally feel like a paranoid person and a paranoid person and someone with obsessive compulsive personality disorder are very bound to date each other, because a paranoid person keeps on double checking, let's say even micromanaging, is like, no, this happened, that happened. But somebody with obsessive compulsive personality disorder will always keep things in a particular way, such that the person who is paranoid will notice that, oh, there is pattern recognition here, there is a pattern here, so things are in order. And then antisocial and narcissistic are bound to date each other. Histrionic and narcissistic and dependent are bound to date each other, because someone with narcissistic personality disorder always wants to be wanted, and they are a bully really, and they never let go of their supply. And a dependent is going to be stuck on the cycle of it's going to be stuck on triangulation that people with narcissistic personality disorder come with. They are going to be stuck on the very highs that person with narcissistic personality disorder comes with, let's say in NPD. And then even if the person with NPD treats them badly, they will want to wait for when they'll be treated well, even if they are discarded. There is a way they do not see their inherent self-worth, so they'll be stuck with the narcissistic person. Someone who is histrionic, I look at histrionic to be like with hysteria. Someone who is histrionic and someone who is antisocial, I feel like they would not go together. They really would not. But the person who is antisocial might like the high they get from the histrionic person. Because someone who is antisocial is someone who generally does not conform to societal norms. And in a nutshell, in quotes, I would say people with antisocial personality disorder, most of them are behind bars. And someone who is avoidant would not make it with someone who is histrionic. And our lecturer also said that two narcissistic people cannot be in a relationship together. But I tend to think that covert narcissists and overt narcissists tend to be with each other. But it still makes sense. Two narcissists really would not be able to stand each other. Explain risk factors for substance use disorders. Risk factors include genetic predisposition. Somebody can be born with alcohol fetal syndrome. Did you know that a woman who does not drink at all can give birth to a child with alcohol fetal syndrome, simply because the man who contributed to the sperm is an alcoholic? Did you know? Surprise, surprise. Family history of substance misuse, peer pressure, early exposure to substances, trauma and adverse childhood experiences, mental health disorders, chronic stress, low socioeconomic status, easy access to substances. For instance, somebody who is brought up around so many bars, like if there are bars and pubs just lining your street, or your parents used to own, or their parents owned bars and pubs, or their parents were distributing alcohol, that's easy access. Alcohol or drugs. Describe eating disorders according to the DSM-5 tier. The DSM-5 tier recognizes several feeding and eating disorders, including anorexia nervosa, which is restriction of energy intake leading to significant low body weight, intense fear of gaining weight, and disturbed body image; bulimia nervosa, recurrent binge eating followed by compensatory behavior such as vomiting, fasting, or excessive exercise; binge eating disorder, recurrent binge eating without regular compensatory behaviors accompanied by marked distress. Which makes me wonder, do people who do mukbangs have binge eating disorder? I do know many of them actually don't swallow the food. They just put in their mouth and they spit out. They have like a bin or something to spit out in. And I think that can contribute to either anorexia nervosa or bulimia nervosa. And anorexia nervosa because of cyberbullying and the whole idea of what's the ideal body type. So now you see they have an intense fear of gaining weight from what they're eating, that's what's making them money. And then bulimia nervosa, that those who actually eat but they go and throw it up. They throw it up because they're like, I'm not keeping all of that in my body. And the more they do that, the more they condition their brains, even their body, their system to function in a state where they keep on throwing up and throwing up. Avoidant stroke restrictive food intake disorder, ARFID, and it's talked about a lot on social media. Restricted food intake leading to nutritional deficiency or weight loss without body image disturbance. So someone with ARFID is not even concerned about the body image, but it's restricted food intake leading to nutritional deficiency or weight loss without body image disturbance. Explain dissociative disorders. Dissociative disorders involve disruptions in consciousness, memory, identity, emotion, perception, or behavior. Major disorders include dissociative identity disorder (DID), dissociative amnesia, depersonalization, derealization disorder. Did you know that pregnancy, childbirth, can make you develop amnesia? They are often associated with severe trauma and can significantly impair daily functioning. Childbirth is severe trauma, by the way. Discuss ethical issues in psychiatric diagnosis. Key ethical issues include obtaining informed consent where possible, maintaining confidentiality and privacy, avoiding stigma and discrimination, ensuring accurate and evidence-based diagnosis. That is like psychologists who are performing psychometrics, but they are not trained in the tests that they are giving out. For example, I do not know if in diplomas or higher diplomas psychometric training is conducted, and then you find someone with a higher diploma or even a certificate in counseling psychology is administering tests. If you're not trained in psychometrics, if you're not trained to administer certain tests, do not do that. That is unethical. Even if you feel like out of the goodness of my heart I want to help someone by diagnosing. Psychology, the practice of psychology is not an out of the goodness of my heart. Now remember, dual relationships coming when you start thinking out of the goodness of my heart. Why? Ask yourself. Go for supervision. Respecting patient autonomy and dignity. Practicing within professional competence, considering cultural and contextual factors, using the least restrictive interventions and safety is a concern. Explain cultural considerations in diagnosis. Culture influences how mental distress is experienced, expressed, and interpreted. Clinicians should recognize cultural beliefs and values, differentiate culturally accepted behaviors from psychopathology, be aware of culture-bound syndromes and idioms of distress, use culturally appropriate assessment tools when available, avoid bias, stereotyping, and ethnocentric assumptions. Consider language, religion, family roles, and help-seeking practices. Incorporate the DSM-5 TR cultural formulation interview where appropriate to improve culturally informed assessment. Yeah, those are the 20 questions. Maybe some of my answers are not correct. I'm open to corrections. Let